Okay. Yeah, I see like we have a wide range of audience. I imagine like non-neurology people, we have medical students, we have our neurology people. So for those who don't know me, I'm Dia Hamoud. I'm one of the stroke neurologists who joined Erlanger 8 months ago, maybe. Time flies. On my background, I'm stroke trained, stroke fellowship trained. So I like strokes, not to have them or for other people to have them, just to treat them, just to be clear on that. And today I'm going to talk about intracranial athero, most commonly referred to as ICAD, intracranial atherosclerotic disease. I like to call it ICAD. Most people like to call it ICAD. Some literature will refer to it as ICAS, intracranial atherosclerotic stenosis. But I like to call it ICAD. I feel it's more inclusive term. And as you will see, it's not just about luminal stenosis. ICAD can cause stroke by different mechanism and not necessarily stenosis. Unfortunately, I have no conflicts. Okay, so what's ICAD? I think the name is self-explanatory. If you're thinking what I'm thinking, you are right. Intracranial athero is atherosclerosis of the intracranial arteries. So what are the intracranial arteries? You can see here the intracranial arteries, including the intracranial portion of the ICA. Let's use the pointer. The intracranial portion of the ICA starting from here. Then you have the clinoid, supraclinoid portion. The cavernous portion is extradural intracranial. Once it punctures the dura, it kind of floats on the CSF. So the circle of Wills actually is floating in the spinal fluid. And then we have the clinoid, supraclinoid segments, and eventually you have the MCA and ACA branches, M2s, M3s, A2s, A3s. And in the posterior circulation, you have V4. V3 will puncture the dura and becomes V4. Once it becomes V4, this is the intracranial portion. So V4 and the basilar artery, the PCA, are all intracranial arteries. How about the petrous segment here of the intracranial artery? The petrous segment inside the bone, takes like an S shape in the skull in the sphenoid wing. And I think the jury is out on that. Some people look at the petrous portion as intracranial. I tend to look at it as extracranial, like most stroke neurologists, I think, will agree. And I've seen like a couple of cases, treated as extracranial and got stents, and they did very well for the petrous portion. That doesn't include the perforators, that does not include the lenticular striate perforators of the MCA. It does not include the basilar perforators. It doesn't include the perforators of the PCA, the thalamo-geniculate perforators. How about PICA, ICA, and the SCA? Are they part of the ICAD? I don't think I read like any explanation for that anywhere. I would say no, because at their core they are perforators. They are large perforators. I would say they are the same at the anterior choroidal artery, which is a large perforator, in the anterior circulation, or the posterior choroidal artery. So these arteries are at core just modified perforators. They're still lacking the muscular layer and the adventitia. And definitely when the ICAD trialists, were thought about ICAD, they didn't regard these arteries, PICA or ICA, as part of the ICAD. Okay, this is what we talked about. So this is intracranial. How about athero? The origin of the word athero came from ancient Greek of athera, which means gruel-like. Anybody having lunch? you know, so gruel-like, and this is gruel. And you see here like gross specimens of the intracranial athero. See here a very nice circle of Willis. except that it has like an athero building up everywhere. You see here cross-sectional normal arteries here, and this is the atherosclerosis building up here. So yeah, I think if you scrape, this athero, it will be like gruel. So what's atherosclerosis? It is very complicated. Needless to say, people spend their careers trying to understand atherosclerosis. But simply you get like intimal injury, you get lipid deposition in the subintimal tissue, and that will attract macrophages. Macrophages will start engulfing these fat cells and transform into foam cells. And macrophages, I think of macrophages like a pharmacy circulating in your blood. Definitely the macrophages carries an amount of cytokines and interleukins and inflammatory mediators more than a drugstore. Once you activate macrophages, they will start recruiting other inflammatory cells, monocytes and lymphocytes. So it will be like a party over here. And eventually these macrophages will explode, and always like free fat will invite calcium. So you start to getting this calcification. It's kind of part of like liquefactive necrosis process, like we see in the pancreas. You get this calcifications in the wall of the arteries. Macrophages with the inflammatory mediators will promote new vascularization to support this plaque, so you get like very fragile capillary network or network of vessels. That's very fragile and very easy to rupture. So you can have intraplaque hemorrhage. Yeah, this is just to simplify, but it's this way more complicated process. It's not unique to the intracranial arteries. We see it definitely everywhere. The first fatty streak will like the intimal injury will start maybe a decade to 2 decades before you have the first fatty streak. In autopsy, actually, you can see it as early as kids. At 10 years old, they'll have like fatty streaks and atherosclerotic changes in their aorta, in the ascending and descending aorta. And maybe like your 20s, your 30s, you'll start to have these changes in the coronary arteries. By your 40s, you'll have these changes on the intracranial arteries. This seems to be lagging a little bit in the intracranial circulation, but not all plaques are the same. We have what we call vulnerable plaque. Some people would call it hot plaque, and we have a stable plaque. Vulnerable plaque will have a very thin fibrous cap, will have a large lipid content, will have a many inflammatory cells, and will have few smooth muscle cells. As this plaque stabilizes, then it will have a thick fibrous cap protecting the content of the plaque. It will have a smaller lipid content. It will have few inflammatory cells, and will have dense extracellular matrix. What can transform a vulnerable plaque to a stable plaque? And this is the basis actually of our treatments today. Managing your vascular risk factors, lower LDL, higher HDL, decreasing the insulin resistance, managing the blood pressure. These are, you're going to transform a plaque from vulnerable to stable plaque. And this is the histopathology of atherosclerotic plaque. As we said, like atherosclerotic plaques basically are foci of inflammation. But like macrophages and all these inflammatory cells and inflammatory mediators in the wall of the artery. So here, like the CD4, the CD68 marker. This is a marker for macrophages. The CD molecules are like channels on the surface of the immune cells to communicate with each other, basically. So we have the CD68. This is a marker for macrophages. And we see here all this kind of brownish stain. It's kind of staining macrophages here. This is important. I like this figure because you can see here, this is like a very minimal plaque. Imagine we're inflating this lumen to its full extent. there is no stenosis, you don't see like any stenosis. It's very minimal, like definitely on a CT angio or a catheter angio, I wouldn't tell. But yet when you stain it with the macrophages marker and metalloproteinases, there are markers for vulnerable plaque as well. You can even have vascular growth factors here in the plaque. Then you have actually a vulnerable plaque, that's not causing any luminal stenosis. And this is why I like to call it ICAD, not ICAS. It's not just about the stenosis, but vulnerable plaque can be a source of luminal thrombus without necessarily causing luminal stenosis. And this is a very important point, and I can make an argument that a big portion actually of our cryptogenic stroke are related to substenotic or non-stenotic ICAD. And this, in the last year or two, a lot of people started to use this term, substenotic, non-stenotic ICAD, and that will explain a lot, actually, to explain why the trials for anticoagulation, not like very positive or negative studies for blindly anticoagulating cryptogenic strokes, and some people speculated might be 20 to 25% of our cryptogenic stroke related to substenotic ICAD like that. So this is a good histo for plaque rupture. You get this thin fibrous cap, and at some point you get like plaque rupture here, and the subendothelial tissue will be exposed, and that process, I see here, it will promote platelet aggregation, promote thrombus formation, and can cause the strokes. On a cautionary note here, not all luminal stenosis are atherosclerotic. There's like a broad differential for this. There's like an array of infectious and autoimmune vasculopathies or vasculitis, moya. Healed dissections can look like ICAD. This one is healed dissection. Subocclusive thrombus. This is a subocclusive thrombus. It can mimic an ICAD. Non-atherosclerotic aging. I will talk about that. But in real life, I feel we may overcall ICAD. For us, intracranial ather was like a surrogate for ICAD, especially for older people with vascular risk factors. Probably for me and probably for other people, the challenging case is usually a younger patient in their 30s with maybe vascular risk factors, but they also maybe have a background of autoimmune diseases. So these patients, sometimes autoimmune vasculitis can mimic ICAD and can be very challenging to diagnose. So without a story, without a clinical context, try to be cautious about calling it ICAD. Non-atherosclerotic brain aging, look at this. This is like the internal elastic lamina and projecting out this all intima and healthy intima. Turns out just the flow of the blood, for 40, 50 years can cause intimal thickening, that's not ICAD. So think of it as the wear and tear of your arterial walls, So there is non-atherosclerotic brain arterial aging process that happens over time. So what's different about intracranial artery versus extracranial artery? First thing you'll notice here, it's way thinner, it's way thinner. You can with the naked eye, you can tell. Second thing you'll notice here, they are lacking the external elastic lamina. External elastic lamina here in the extracranial arteries. It's in the coronary arteries and the peripheral arteries. They all have external elastic lamina. We don't have it here in the intracranial arteries. Look at the smooth muscle. Look how much the smooth muscles are here. You have less smooth muscles and thinner layer of smooth muscle in the intracranial arteries. Look here at the vasa vasorum. This is the blood vessel, the blood supply of the arterial wall itself. Here, because they are thin, they are floating in the CSF, they get their oxygen demand from the CSF, so they didn't have a well-developed adventitia with vasa vasorum. They have tight junctions here, which form the blood-brain barrier. But like in brief, they are thinner. They're lacking external elastic lamina. They are defective, a little bit defective in the muscular layers and in the elastin. The blue here is the elastin of the muscular layer. So they are not very elastic. Like compliance and elasticity are less than extracranial arteries. That means you cannot really play around, with the intracranial arteries. Like, for example, the coronary artery, you can inflate it to double of its diameter and it will recoil, nothing will happen. But the intracranial arteries, you cannot do that, they will rupture. Okay. And for me, what's ICAD? This is what I would call ICAD. I will see this is actual patients. This is reconstructed CTA. You see like the basilar here, the narrowing and irregularities of the basilar. Look at this segment. Look at this segment here, like very irregular basilar. Look here at the MCA. This is, I would call it ICAD. ICAD. Look here at the distal M1 or an M2, ICAD, ICAD, ICAD. So once I see like this pattern in a patient in the stroke alert in the CT angio, I think ICAD. Epidemiology, yeah, let's begin. So ICAD accounts for 30 to 50% of strokes in Asian population. Talking about Asian population, including Chinese, that would make it the most common cause of stroke worldwide. 15 to 29% of strokes in Black population, 10% of strokes in Caucasians. We see a fair amount here, but I can attest actually, the difference between Black and Caucasian population, having worked like at Grady Memorial in Atlanta, Midtown Atlanta, 85% of the patients were African American. It was very, very, very common. Every other patient will have ICAD, but we have a fair amount here as well. Why is common in Asian population? We're not really sure. We know like hypertension is more common in Chinese population. We know that metabolic syndrome and diabetes may be more common in Hispanic. But maybe it's environmental factor, something they eat, something they smoke, genetic susceptibilities, so we're not really sure. Cliche. Next. These are the patients who came into the hospital and they had a stroke. How about patients who are just living at their homes, minding their own businesses? So want to get a feel about the burden of ICAD in the community out there. So we have two population-based studies. One of them, ARIC, started in the 1980s. And ARIC was a population-based study. They went to people, healthy people, at their houses, and they longitudinally followed these patients for more than 30 years in 4 U.S. major cities. They ended up doing an MRA on 1,900 patients, and they found what you may call ICAD in 34% of the screened patients. Then we have the famous North Manhattan study. It was a population-based study. It was like a very multiracial cohort, a very diverse group of patients. And they defined ICAD, any degree of luminous stenosis you may call ICAD. It was like 40%, similar to the ARIC cohort. And when they looked for luminous stenosis more than 50%, 8% of the population out there, they had ICAD more than 50%. So it's like a high burden of ICAD, even in asymptomatic patients out there. How about autopsy studies? 60 from the age of 60 to 69, 43% of the autopsies, they had ICAD. As you get older, the burden will increase from 70 to 79, 65% of the patient, and older than 80, more than 80% of the patient actually had a degree of ICAD, and that's very similar actually to the atrial fibrillation. Risk factors, we have non-modifiable risk factors, age, and as we saw, as we get older, more likely we have ICAD. Race is more common in Asian, then Hispanics, then Black, then white. It's like the exact opposite of extracranial disease. You can go the exact opposite for extracranial and you'll be right. It seems equal in males and females. And something else, the anatomy of circle of Willis, it's non-modifiable risk factor. You cannot change that. But and it's more like flow dynamic issue, the anatomy of circle of Willis. Like, for example, here, this is, maybe a complete circle of Willis. You see the hexagonal shape here for circle of Willis. But look here, for example, and this is very, in real life, you don't see that. In medical school, maybe everybody looks like that. But we have like hundreds of variation to the circle of Willis. Most often it's incomplete circle of Willis. Look here, for example, you have like a fetal PCA. You have the posterior cerebral artery actually coming from the anterior circulation. Here you have a very small P1. So these like variation of circle of Willis will put like strain and high flow on certain arteries, and factor that, with every heartbeat for your entire life, will have like a strain on this artery. So for example, this patient, maybe there is no much strain on the basilar artery. Its job, just ends up at the tip of the basilar. Its job not to supply the posterior circulation, but it will put like a lot of pressure, a lot of strain on the anterior circulation, on the ICA here. So this like very, very complicated. It's more physics than medicine. So let's go to the modifiable risk factors. Higher systolic blood pressure, and for the stroke trialist, they like to use high systolic blood pressure as a surrogate for hypertension, but you can go with hypertension as well. Diabetes, but higher A1C does not correlate with the severity of the ICAD. Imagine like it's a very complex interplay. Dyslipidemia, total cholesterol, and LDL correlated with ICAD, and sedentary lifestyle, tobacco abuse. I think there's no surprises here. Everything is as expected. And this is like maybe the most important part of this talk, the mechanism of a stroke in the ICAD. And this is when ICAD start to be a little bit different. How can you have a stroke from ICAD? Actually, we have different mechanism. You can have artery to artery embolization, and for artery to artery embolization, you don't necessarily have to have luminal stenosis. Remember the figure I showed you early on, that substenotic ICAD, you can get intimal injury and you can form like clots that embolize distally. So artery to artery embolization, impaired distal perfusion or distal hypoperfusion or hemodynamic stroke, can, I would call it impaired distal perfusion. And this one you have high grade stenosis. You have a stenosis, and then distally you have border zone areas lacking blood, and then you get like a border zone or watershed pattern of these strokes. And this is third mechanism is unique about intracranial arteries. We don't have this in extracranial arteries, with perforator disease. Some people call it branch erytheromatous disease. And this is when the ICAD will encroach on an ostium of a perforator arteries. Don't forget we have all these perforators coming from the basilar, from the MCA, from the PCA. How about if you have a clot that caused complete occlusion of the lumen? Then we're not talking about ICAD anymore. We're talking about emergent LVO. And we should treat it as emergent LVO. Interventional neurologists and neuroradiologists, they don't like ICAD. They don't like ICAD. And actually the newer trials, for microcatheters, they're trying to exclude these patients. But the endovascular trials, they included patient with ICAD. They included patient with ICAD. In the sub-analysis, we know that these patients will not do as good. They will not do as good from endovascular interventions, but still it's recommended and it is safe in patients with ICAD. This is a real patient. In July 2020, came in with the left MCA syndrome, NIH of 8, M1 complete occlusion here. And this is after a thrombectomy. You see here this segment, this is ICAD, and this is the problem about ICAD. It's not like a lumen disease, It's not like a clot like AFib. You're gonna just take it out and then you're gonna restore the lumen. No, it is like a vessel wall disease. So, and you can imagine why, most interventionalists, they don't like ICAD, Just imagine having to pass a microcatheter here and to pass a wire and to deploy a stent retriever or do like contact aspiration, whatever method they're gonna use. And then after that, you got this, Very often, actually, these arteries will just shut down because as you go, the microcatheter will cause more intimal injury, So this patient, when I see a patient that looks like ICAD and going for endovascular, I load them with aspirin and Brilinta right away because we anticipate, this trouble. So the same patient, July 2020, discharged with NIH of 3. October 2020, on maximum medical treatment, came in with another LVO. LVO had another thrombectomy, and you can see the ICAD still here, So you do thrombectomy and then you start another round of maximal medical treatment, and we're always here to do thrombectomy. We'll keep doing it. Okay, and this is a nice figure to summarize the mechanism of a stroke in ICAD. This is an ICAD with plaque rupture and have like a huge clot causing a complete occlusion, emergent LVO, treated as an LVO. But for ICAD, this is a plaque. It might be substenotic or non-stenotic. And then you have like intimal erosion here. Then you start to form these clots, subintimal exposure, platelet aggregation, platelet adhesion aggregation. You form these kind of small clots, kind of flicker distally. And then you have this like embolic pattern, artery to artery embolization in the territory of the ICAD artery. This is impaired distal perfusion. You have high-grade stenosis here, kind of impeding on the blood flow. Then distally, you'll start to have border zone, border zone or watershed infarcts distal to the stenosis. And then this is the perforator pattern. You have this atherosclerotic plaque encroaching on the ostium of perforators and causing perforator pattern stroke. Okay, so by looking at the image, sometimes we can tell, most of the time actually we can tell how ICAD, what mechanism ICAD caused this stroke. We can call it territorial pattern when you have artery to artery embolization in the territory of the ICAD artery. You can call it border zone pattern. If you have border zone pattern distal to the ICAD, you can call it perforator pattern. And there's mixed pattern. These are some examples. So yeah, let's do this exercise together. So a panel here, for example, like all these patients, I assume, they have like ICAD in the MCAs. So there's like a perforator pattern, if I see like an MCA with stenosis and irregularities, I would say, this is a perforator pattern, probably this atherosclerotic plaque encroaching on a perforator. This pattern, for example, you see here, these strokes, water, deep border zone infarct. Very typical border zone infarct. So this, you kind of anticipate a high-grade stenosis with border zone infarct, impaired distal perfusion mechanism. Look here, see like these strokes here and there. So this pattern, I would call it artery to artery embolization, all in the same vascular territory. You have ICAD M1 here. Look here, this is what we call like cortical border zone infarct, cortical watershed pattern. So that expect to be impaired distal perfusion as well. This guy, I'm not sure why is included here. Looks like the superior division is gone, and this may be like artery to artery embolization, territorial pattern as well. WASID and SAMPRS trials, one of the two major trials I'm going to refer to a lot. I'm going to talk about them in details. But how about the numbers? Like WASID trial, one of the ICAD treatment trials, included patients with more than 50% stenosis. And in the sub-analysis, they found just 8% they have border zone pattern, 8%. But notice they have included ICAD causing more than 50% stenosis. They have like 50% stenosis with territorial pattern, 25% with perforator pattern, and the rest is mixed pattern. But when the SAMPRS trial include patient with high-grade stenosis, 70% as opposed to 50%, we started to say like border zone pattern, it was almost like 50%, territorial pattern 23%, perforator pattern 23%. So it does make sense now, the higher the degree of the stenosis, the more distal hypoperfusion you will get and the more border zone pattern you will get. Diagnosis. And this is when the challenges begin for ICAD. And the matter of fact, we don't have a way to diagnose ICAD, and this is a problem in our practice right now. What you're looking at is not ICAD, this is a catheter angiogram. This is a CT angiogram. You don't see an ICAD, The problem about ICAD, it is a vessel wall disease. It's not like a lumen pathology. It is a vessel wall disease, So what you're saying is a narrow lumen, who knows what might be going there, It might be a rock here, it might be like a small person, pressing on the artery and causing this stenosis, You kind of imagine, maybe a plaque here causing all this stenosis, but you don't see the plaque, and you don't see the extent of the plaque. You don't see what's inside the plaque. The plaque might be projecting outward, the wall of the artery might be here, the wall of the artery might be going here, you might have some hemorrhage in this plaque, So you don't see the ICAD. You're using like a surrogate marker with the luminous stenosis that there's probably an ICAD here, but you don't really see the ICAD. And this is the problem now, that all our diagnostic modalities are lumen-based studies, including the catheter angiogram itself. So everything was compared to the gold standard for diagnosis, the catheter angiogram. This is the most accurate, most specific and sensitive method to diagnose ICAD. So the TCD, transcranial Doppler, some institutions are big in using TCD, some are not, but anyway, like positive predictive value, 36%, negative predictive value, 86%. Like in short, it's a sensitive study, and the more you increase like your velocity measures, the more specific and less sensitive you will get, So it is, and it's like operator dependent. Another problem about it, you should have like a very good sonographer for the TCD. It has a lot of technical limitation. Then the MR angio, which used without contrast, use like time of flight technique. Positive predictive value, 59%, negative predictive value, 91%, means like it is a sensitive but not a specific study. And MRA, it's almost always exaggerates on the degree of the stenosis. It makes sense. But look at the CT angio here, the CTA, positive predictive value, 93%, negative predictive value, 99.8% as compared to the catheter angiogram. So by far, the CT angio is better, having like latest technology and MRA is not necessarily more accurate or better, like by far, every time I would prefer to get a CTA over an MRA time of flight. So the CTA is very specific, very sensitive, is very comparable to the catheter angiogram, and this is what we use. But I complain about a lot about not having diagnostic modality, and they are all human-based. But let me introduce you to the high-resolution MRI, intracranial wall arterial imaging. This is a new technique, new modalities. Some institutions are very big in the visual wall imaging, and it's meant to supplement the MRA. and they add contrast to enhance the wall. So look here, this is a time of flight MRA, and this is always exaggerating as always on the degree of the stenosis. And then look here, this is like the visual wall. This is the lumen, this is the lumen, and this is the visual wall. This is the visual wall. This is the visual wall, enhancing here, post-contrast visual wall. So it is good, you know. It's not validated, it's still in early phases, but in the future it will be something. The visual wall imaging, you know, is something much needed actually in our practice. So another example here, you know, this is MRA, reconstructed MRA, exaggerating as always. And then you have here like the visual wall. This is a longitudinal cut. And then here, you see like the inflammation. We said like atherosclerosis inflammation of the visual wall. See how it's enhancing here. Okay. Not just you can see the athero, but you can see the content of the athero. You can see the intraplaque hemorrhage. They use different sequences to see whether it's vulnerable plaque or stable plaque, you know. So here, you know, you see the intraplaque hemorrhage. This is the histopathology. You see here the lipid content, this hypointensity here, you know. So, okay, so high resolution visual wall MRI imaging, it is evaluation of the arterial wall rather than the lumen only based studies that we used. And it's able to inform about the possible differentials using the pattern of wall thickening and enhancement. Like, yeah, radiologists can tell, you know, whether it's vasculitis, whether it's ICAD, whether it's like a Moya pattern, can tell whether it's a subocclusive thrombus. So it will be useful actually in differentiating, you know, what's causing the luminal narrowing. But the disadvantages requires like a high power magnet, at least 3 Tesla. It's not really available, and it's not validated in clinical trials. And this relatively low resolution, it's 0.5 millimeter voxel compared to the average brain arterial wall diameter is 2 to 3 millimeters. So, you know, there's still some work to do here. You know, somebody need to do this work. And then management. 1955, with the invention of the warfarin, that was a mere accident like most of the great drugs. So 1955, we started to have the warfarin, and we start to see reports actually in the literature about anticoagulating these patients, you know, studies in cerebrovascular disease, the use of anticoagulant drugs in treatment of insufficiency or thrombosis within the basilar artery. So they use like warfarin in this paper for basilar stenosis, and they were happy with it. But like for 40 years, you know, we see like things were different, you know. 40 years ago, just 30 years ago, things were very different, you know. Stroke was not, there was nothing to do for the stroke patient 30 years ago. You get a call overnight, a patient coming with a massive left MCA stroke. You just, yeah, tell the ER doc, you know, just admit him. I'll come to see him in the morning or maybe tomorrow. You know, I have neuropathy patient I have to see first. But it was not like a priority at all, yeah, and there was nothing to do about these patients. But yeah, for 50 years, we see like reports about people using different anticoagulants, and things were different, you know. We don't see like a well-designed trial comparing, you know, two arms head to head. Even they used to have a different style in writing, you know. It's more elegant, poetic way of writing, you know. But and then from 1955, in the 1980s, the bypass trials, external carotid to internal carotid bypass trials, actually we have two large trials conducted in the 1980s. And it is reasonable, very intuitive thinking. You know, if you have a blockage, just try to bypass it. So we have something called STEMCA. They call the STEMCA, superficial temporal artery to middle cerebral artery bypass. Superficial temporal artery, which is part of the external carotid artery, you just poke a hole in the skull and connected to the middle cerebral artery, bypassing the stenosis. So it's very intuitive, it's basic plumbing concepts. If you have a drainage problem, in your house, probably I'll try to do something like that, use a plunger or drop in a stent or do something. But it didn't really work. I'm not sure why. Like in specifically patient with severe MCA stenosis, and this was like more than 100 patients underwent bypass surgery and has significantly higher rate of stroke compared with medical management group. Like 44%, they had complication with the STEMCA surgery. So this is not acceptable, 44%. And then by that time, we started the warfarin aspirin symptomatic intracranial trial. And this is actually the first trial you found, that was modern trial, well designed, and published in 1995, although they recruited patients from 1995 to 91, took them 4 years to publish the results. But it was like a multi-center trial, modern trial for a patient for more than a year. And they compared warfarin to the aspirin. And this particular study, actually, they compared way better outcomes with the warfarin arm over the aspirin arm. So in the late 1990s or late 1980s, early 1990s, a lot of people used the warfarin at that time, but then we have like conflicting reports about warfarin and aspirin, and there was like a division in the stroke community by that time, and that led to the WARS trial. WARS trial, it's this famous trial. They randomized more than 2,200 patients. This is a huge number and probably the largest trial regarding the numbers for the ICAD, if not for the stroke in general. So the WARS trial started recruiting in the mid 1990s, and they published in the early 2000s. They randomized more than 2,000 patients, and the two arms, including the warfarin, and the INR was like on the lower side, 1.4 to 2.8. This is definitely not the target that we'd use now for anything, versus aspirin, 325 milligrams. By that time, remember, people, like neurologists didn't pay that much attention about stroke etiology. Like cardioembolic, ICAD, we started actually to understand, there's different mechanisms of a stroke, after the NINS trial in the mid-90s, 90s, and the TPA trials. But for the worst trial, they tried to exclude patients with cardioembolic stroke, but included all the others, including lacunar infarcts. More than 25% had cryptogenic infarcts, 50% had lacunar infarcts. So it had like heterogeneous causes of strokes. And the median follow-up was 2 years, and the rate of recurrent strokes was 17.8 in the warfarin arm versus 16% on the aspirin arm. Rate of hemorrhages around 2% were similar, and the rate of recurrence were similar as well. I remember like this number, around 16, 17% of the patient had recurrent stroke in 2 years. So they concluded, like, yeah, both of them are good, whatever you want to use at that time. You want to use aspirin, you want to use warfarin, and that led to the WASID trial. The WASID investigator actually surveyed large number of neurologists at that time, what they are using, and there was a division in the neurology community. Some people used antiplatelets, some people used warfarin with different targets of INR. So that ended up to the WASA trial. It's a very important trial, one of the landmark trials for the ICAD. And WASA trial, they started recruiting in the late 1990s, and they published in 2005. So it's still like in the early 2000s. I'm not sure what to do with the ICAD. So in the WASA trial, they recruited more than 550 patients with 50% to 99 stenosis, So they included like mild stenosis, ICAD, I would say, more than 50%. And the two arms, one with aspirin, a mega dose of aspirin, I've never seen before, 1,300 milligrams of aspirin, versus a warfarin with INR of 2 to 3, the standard INR we use now, 2 to 3. And the primary outcome is ischemic stroke, brain hemorrhages, death from vascular causes other than strokes. And the study was terminated prematurely because significantly higher hemorrhagic complications of warfarin. 8 patients had a hemorrhagic complication with warfarin versus 3.2% with aspirin, not just aspirin, 1,300 milligrams of aspirin every day. The mean follow-up was almost a year and a half, and there was no difference, or 2 years, there was no difference in ischemic stroke outcome. And again, you see like the same number, like it was 20% versus 17% to the warfarin versus the aspirin arm, with still, in the range of 17, 18% risk of recurrence in the median follow-up, almost 2 years. The rate of recurrence correlated with the degree of the stenosis. The higher the degree of the stenosis, the more recurrence you had, which is reasonable. It's very intuitive because remember the mechanism of stroke in the ICAD. So you add a different mechanism. You add impaired distal perfusion. It may reflect vulnerable plaque when you have a high grade stenosis. So the WASO trial concluded that no overall benefit of warfarin over aspirin, and it almost killed the idea of using anticoagulation for ICAD, including like no benefit, including the more severe stenosis. Like people thought patient with more than 70% stenosis may benefit from the warfarin over the aspirin, but that proven not to be true after the WASO trial. Another issue with the warfarin was maintaining the INR within this therapeutic range. So the percentage of time spent in the target INR was just 63% versus the aspirin mega dose 1,300. The compliance rate was 94%. And we learned from the WASO that INR less than 2 significantly increased the risk of a stroke, and INR more than 3 significantly increased the risk of hemorrhage. So by that time, in the early 2000s, after the WASO trial, people, start to abandon the idea of anticoagulation or warfarin for ICAD. But we learned like valuable lessons from WASO trial. Before the WASO trial, there was no sense how bad your risk factors, vascular risk factors for ICAD. We had trials. Most of them were industry sponsored or pharmaceutical sponsored. And when pharmaceuticals design studies, they always go for the composite outcome. They want to like a big target. They'll go for composite outcome of heart attack, for stroke, all causes of a stroke, for peripheral vascular disease. So you have things like Sparcel trial that use a statin. And we know like statin is probably good, to prevent you from having a heart attack or having a stroke, regardless of the etiology. We know like controlling your blood pressure probably is a good idea, but they didn't enforce that in the WASID, maybe you tell your patient, see your primary care doctor and take care of your other issues. But in the WASID trial, the vascular risk factor control was for standards of care at that time. But then the data we had from the WASID showed actually the importance of controlling vascular risk factors for ICAD. We noticed that people who were able to maintain their systolic blood pressure less than 140 had lower rate of recurrence. And that was very significant, statistically 31 versus 18%, maintaining your blood pressure less than versus more than 140 on clinic follow-ups, and this idea, dispelled like the hypothesis of maintaining higher blood pressure. People intuitively thought if you have a high-grade stenosis, probably it's a good idea to keep your blood pressure on the higher side, try to overcome, this stenotic segment, and increase the distal perfusion by maintaining higher blood pressure. But that proven not to be right. And the total mean people with hyperlipidemia with cholesterol more than 200, they had higher rates of stroke, and that was statistically significant as well. 26% versus 19%. And people with hemoglobin, uncontrolled diabetes, hemoglobin A1C more than 7, they had more recurrent events. So WASA trial was like an eye opener that vascular risk factors are crucial for ICAD. And that led to the next trial, which is SAMPRS trial. It's like a trial here, the Asian version of the WASA trial. Recruited 350 patients from Singapore and Hong Kong. And they use like low molecular weight heparin, nadoparin versus aspirin 160, and for like similar results, and that killed the idea of anticoagulation even more. But let's talk about the SAMPRS trial. SAMPRS trial, the most important trial I'm going to talk about today, and probably the most important trial for ICAD. WASA trial was published in 2005, and by 2005, the medical device industry were in a good place. We have something called wingspan stent system. It was just approved by the FDA in 2005. They had 2 registries, each enrolled more than 150 patients, and they reported maybe like 6% rate of pre-procedural complications. Remember, we have like at that time, early 2000s, we had risk of recurrence 16, 17%. So the wingspan system, yeah, they had like pre-procedural complication rate of 6%, but that was acceptable. So the FDA went ahead and approved the wingspan stent system. The wingspan system is what we call self-expandable stent versus balloon expandable stent. Each has advantages and disadvantages. The problem with the wingspan works like this. You go with a microcatheter with a balloon, inflate the balloon, and then remove the wire. So you would have to remove the wire. It's multi-step delivery system. And then you go in with the stent that should be carried on a wire. So you go with a wire again through the lesion, and then remove the sheath, and the stent will expand like that. It looks very good here when you see it. Very smooth, very easy process. So SAMPRS trial, they published the results in 2011, and SAMPRS trial compared the wingspan stent, which is very promising, very intuitive, very reasonable treatment at that point, versus everything we learned from the WASA trial about the vascular risk factors. So we had 2 arms, maximal medical treatment arm versus percutaneous transluminal angioplasty and stenting arm, PTAS, we call it like balloon and stenting arm. We learned from the WASA that early initiation of treatment is very important. We learned that controlling the blood pressure less than 140 is very important, and 130 if you're diabetic. We learned that LDL, lower goals of LDL are very important. And they were like very vigilant about lifestyle modification programs. Actually, they have personal coaches to these patients. They used to call them, and they implemented a lifestyle modification program, including physical activity, weight loss, nutrition, and smoking cessation, things like that. And they recruited 450 patients with symptomatic ICAD. A difference between SAMPRS and WASA trial and SAMPRS, they went for high-grade stenosis, 70% and more, 70% and more. And the results of that SAMPRS were shocking. Actually, they were very disappointing at that point. The primary outcome was a stroke in the territory of the qualifying artery or death at 30 days. And they planned actually to recruit more than 700 patients, and ending up with terminating the study prematurely, and they published the results for 450 patients that were randomized between 2008 and 2011. Why they terminated the study? Here it is. We have 14% complication. Primary outcome was met in 14% of the balloon and stent group versus 6% in the medical maximal medical treatment group. So remember the two registries they have for the wingspan reported 6% risk of complication, you know, so 14% was very shocking number at that point. The highly unexpected rate of pre-procedural complication, the 14% were driven mainly by complication during the procedure itself, you know. If they managed to decrease these complications, they would have ended up with a number like the maximal medical management group. And of the strokes that happen in the balloon and stent group, 76% occurred within 1 day of the procedure, and the rest occurred within 60 days of the procedure. And 10 patients had a symptomatic ICH. Some of them actually the wire kind of ruptured, went through the MCA, and they had subarachnoid hemorrhages. There were no hemorrhages in the maximal medical management cohort. So the trend remained at 1 year the same, 20% versus 12.5%. And if you compare these numbers, they are like basically the same, you know. I mean, like the difference is driven by the 30-day outcome, you know, like 14% plus 6%, you get this number, 6% plus another 6%, you get this number. So after 30 days, actually the stent, as good as the maximal medical management, and the end of 32 months, it is the same, still the trend, the same. Okay, so what happened for the balloon and stent group? More than 50% of the stroke, or like a perforator artery pattern, more than 50%. And people who were at higher risk for having pre-procedural stroke, who are those who underwent basilar artery stenting, older age, diabetes, diabetic patient. I think, yeah, maybe there's no surprises here. And non-smoking status, you know, which was kind of surprising as well. So smoking actually protected you from having a stroke, you know. Still, I don't recommend it. But trends actually that nicotine activate Plavix to its active metabolite, you know. Yeah, like nicotine activate the CYP enzyme that convert Plavix to its active metabolite. So, and this is, yeah, and after the balloon stent group and 50% of the strokes were in a perforator pattern, we learned about something called snow plowing effect, you know. And this is like a very nice image, kind of summarize what happened during the balloon and stent group, you know. This is the snow plowing. You have a perforators here, and you have a plaque in between two perforators, and then you go with the balloon and inflate the balloon and then put in a stent, then you snow plow, you encroach in the perforator artery, and then you cause these perforator pattern strokes, you know. So if they just excluded patient with perforator pattern strokes before the stenting, the 30-day ischemic stroke rate would have dropped from 14% to 9%, you know. Other problems with the Sampras trial, the hemorrhages, some were subarachnoid hemorrhages, some were intraparenchymal, mainly related to the reperfusion injuries, and risk factors associated with hemorrhage, higher degree of stenosis, clopidogrel load before the procedure with the activated clotting time above the target range, and earlier window of treatment, which is a very important point as well. Earlier window of treatment. The mean time from randomization to doing the stent were 7 days, just 7 days on the Sampras trial. So These basically are the Sampras limitation, and this is this figure again here to understand. So reasonably, if you have a perforator pattern stroke, you would try to avoid stenting. This is a high risk for pre-procedural complication. I think the problem with Sampras with the stent group was not the procedure itself, but the selection of the patients. So if you have like a patient like this, with a perforator pattern stroke, it is better to avoid stenting this patient, to avoid the snow plowing effect, like the figure we saw. How about if you have a territorial pattern, artery-to-artery embolization, like here? We said like artery-to-artery embolization, you have unstable plaque. It's not necessarily causing impaired distal perfusion. So medical management likely better for these patients. You want to prevent platelet aggregation. You want to prevent distal artery-to-artery embolization. So probably medical management will be better for this subset of patient. But then if you have impaired distal perfusion, a border zone infarct pattern, these patients who are ideal actually for stenting. These patients are ideal for stenting. There was some critique for the Sampras trial about the procedure itself. It's a multi-step delivery system. So crossing the lesion with a microcatheter and then exchange the wire and then go again with the stent. So there's like tons of post hoc analysis and sub-analysis of the Sampras trial. So one post hoc analysis to identify the risk of early recurrence in the medical management group was older infarct in the territory of the parent vessel, new stroke presentation on the same territory, and absence of statin use at the enrollment. And this is problematic because we learned that patients who are at higher risk for early recurrence in the medical management group are the same patients who are at high risk for pre-procedural complication when you go ahead and do the stent. And they even followed these patients up to 3 years, and they found like factors associated with recurrence after 3 years with out-range blood pressure control, high cholesterol, low level of physical activity, again, enforcing the importance of vascular risk control for ICAD. And there was another trial, the VISIT trial. So Sampras was NIH-sponsored. 2 years after Sampras, we had the industry-sponsored trial, the VISIT trial. And VISIT trial used a different stent, balloon expandable stent. And the plan was to recruit 250 patients, ended up recruiting 112 patients. And actually the sponsor halted the enrollment after Sampras published the results in 2011, and they asked for early analysis of the result. And actually the outcome was very similar to the Sampras trial, the intervention group. They didn't do good. We have like more than 30% complication rate versus 15% in the medical arm. So Sampras and VISIT, put an end to the idea of stenting intracranial artery. So right now, the evidence from Sampras and VISIT does not support the endovascular therapy in patients with ICAD, even with high-risk subgroups, because as we said, the same subgroup are at higher complication for peri-procedural complications with the stent. And then after Sampras and the results were shocking, the FDA mandated post-market analysis study that went under the name of WEAVE registry. So they amended their approval for the device, and they mandated on-label strictly on-label use for the device, and they changed the criteria. So they required more than 2 or more strokes despite aggressive medical management. And most recent stroke occurred more than 7 days prior to the treatment with the wingspan. As we said, the time from randomization to treatment with the wingspan was very short, just 7 days. And we'll talk about that. And they required higher grade stenosis, more than 70% stenosis. And these patients should have a good baseline with modified Rankin score of 3 or less, and lesions in no more than 15 millimeter in length, and the target vessel more than 2 millimeter. There's something called Mori criteria about these plaques. And they provided formal training for the interventionalist regarding the best practices they learned from the Sampras trial and pre-medication with dual antiplatelets. They were very strict about starting these patients on dual antiplatelets at least 5 days prior to the stroke. And they used best practice technique with submaximal balloon dilation in the perforator-rich areas. So if you go back to here, how if you have like a stenosis here, what they do with submaximal dilation techniques, you don't inflate it like all the way. You just go 80% or 60%, try to avoid to snow blow it against the perforator. So this is submaximal dilation. And they were very strict about controlling the blood pressure post-op, systolic less than 140, because we've seen like out of these patients, the hemorrhagic complication with the Sampras were related to reperfusion injuries. So the WEAVE registry was the largest on-label multi-center prospective trial with the wingspan, and terminated early actually after interim analysis or 150 patient, and showed only 2.6% rate of pre-procedural stroke or bleeding or death within 72 hours. So this is better than our maximal medical treatment now, and just by selection of the right patient, and they have lower than the 4% pre-procedural safety benchmark. And they published actually in 2009, so the WEAVE registry is not going anymore. And right now, there's like a large study actually going in China. Like the burden in Chinese population is much bigger than Caucasians. But in China, we have the CASIS trial actually running now, and kind of anticipating actually the results. But the preliminary analysis looks very promising. The first 100 patient actually they had 2% risk of stroke, similar to the WEAVE registry, or death at 1 month. And they have like the same on-label criteria like the WEAVE registry. They are very selective about these patients. And this is to summarize all the trials that used the wingspan stent, which is the only device approved by the FDA till this moment, actually, for the ICAD. So we have here the 2 registries of the Sampras trial, and the pre-procedure complication risk is around 6%, and then all of a sudden, boom, we have the Sampras trial with 14%. But then we have some Asian trials, coming with very promising results. We have Jiang, Miao, Zhao, Gao, Ma, and the WEAVE registry. And look here, the pre-procedural complications, all around 5%, 6%, 4%, or even 2%, except the WASUD, except the Sampras trial, So a lot of lessons to learn here from what went wrong with the Sampras trial, Look here, time to stent from the stroke or TIA. Sampras trial was the only trial, actually. We had like within the first day, the first week, they stented these patients. Most of these trials, including like the CASIS trial, the Asian trial, they wait at least for 21 days to stent these patients. So you can anticipate actually how the future will look like, So Yeah, we learned early again that the stenting early within 7 days increased the ischemic stroke risk and the hemorrhagic risk. And because, yeah, if you think about it, it is very reasonable. Like a recent stroke is an indicator for unstable plaque, that may rupture. You have unstable plaque and you go in with a wire and a balloon, and then you exchange wire, and then you deploy a stent. So you're inflicting actually more intimal injury, you know. Um, and the early reperfusion could also increase the risk of reperfusion hemorrhages from the weakened and leaky capillaries from the stroke bed. And this is, yeah, something we learned about even on the thrombectomy trials. And then you load with dual antiplatelets, and then you use procedural IV heparin. So imagine the future, there will be a rule for stenting, but not early stenting. So how about the prognosis of ICAD even with our treatment now? What should I tell my patients? It depends on the location, the size of the infarct, and the mechanism of the stroke. People with hypoperfusion, impaired distal perfusion at higher risk actually for recurrence. But um, something unique about ICAD, unlike all other stroke etiologies, ICAD associated with high risk of early recurrence of a stroke, even with the maximal medical treatment. With all other etiologies, extracranial athero, with AFib, uh, your cumulative risk goes higher year by year. ICAD is the opposite. ICAD, you risk it the highest in the first few days after having a stroke. And we've seen like the number of the Sampras trial, we've seen the numbers in the WASIT trial is here, yeah. WASIT in the Sampras trial, the event rate in the medical arm, 6% within first month, 12% within the first year, 15% within 3 years. So your risk actually increases over time. In the WASIT trial, it was like very same pattern. Um, and we are talking about, when we talk about outcomes in these trials, we're talking about measurable outcomes. We're talking about NIH stroke scale. But there's like several data actually, looking for the burden of white matter hyperintensities, looking for the cognitive decline, like unmeasurable neurological deficits and the classic neurological examination, I would say. So yeah, the burden of white matter hyperintensities was significantly higher in patient with ICAD. It was more than, yeah, compared to patient with extracranial athero or no ICAD. They had more white matter changes. They had cognitive decline. Some looked into the cognitive functions of these patients, and then they had cognitive decline related to the focal or diffuse infarction and white matter degeneration, hypoperfusion. They did actually metabolic scans in these patients, hypometabolism of the documented of these areas. So, what are the challenges in the future of ICAD? The challenges are here with the standard medical treatment. We have 6% risk of recurrence in the first month. I don't like to tell this number, I avoid telling our patients that, but we see it every day. You get a patient with ICAD, and while they are in the hospital, they will have another stroke. So 6% is very high, even with the standard management that we have now with the dual antiplatelets and vascular risk factor control. And then diagnostic challenges like what I talked about, that we don't have studies dedicated for the visual wall. All our studies are lumen-based imaging, but hopefully technology will pick up and will be able to look into the arterial wall. And early recurrence of ischemic stroke within the first 3 weeks from the index event, and that will be a challenge in the next few years. I anticipate actually the endovascular therapy and the stenting will have a role in the ICAD, but I can tell you they will wait at least 3 weeks to stent these patients, and this period are where the patient is very at a very high risk for recurrent stroke. So what are we going to do in these 3 weeks? That will be very challenging for us as a stroke neurologist. And patient selection, identifying patient who would benefit from angioplasty and stenting. I think this is the really challenge about stenting for intracranial ICAD is patient selection. Um, so if you have like an stenosis, like grossly you see a stenosis in a catheter angiogram, can you tell is it like anatomic versus functional stenosis? Is it causing impaired distal perfusion? Actually, there are some concepts we can get from cardiology, which is something they call fractional flow reserve, which is basically the pressure gradient across the stenosis. As we talked before, patient with a hypoperfusion, impaired distal perfusion are ideal for stenting. But how can you tell? Some people trying to use perfusion-based imaging. I don't think the technology is there yet, but some people actually using this, from cardiology, cheating from cardiology basically, and they measure actually the pressure gradient across the stenosis. So if you have like a pressure gradient, less than whatever number you're gonna choose, is still like in early phases, but less than 0.7 or 0.6, then you can say I have a hemodynamic lesion here. I probably have impaired distal perfusion, and this patient will be ideal for stenting. This is like a small series, actually, just for 9 patients. All of them underwent intracranial stenting, and all of them had very good results. And we see here the pressure gradient, all like less than 0.6 or 60%. In other words, they have like a pressure drop more than half, just crossing the lesion, which means they have impaired distal perfusion. Yeah. Okay. So I mean, like, I think the standard treatment for ICAD is still in evolution. It's still in evolution. 6% recurrence rate within the first month is very high. And we have like very promising data. Um, so I think things will change in the next few years in regard to the ICAD. So. Oh, I lost track actually of time. I thought this will take like 45 minutes. Yeah. We have time for questions.
You had mentioned that most of our studies are looking at lumen as opposed to composition, and cardiology sometimes leads the way in some of our vascular studies of the brain, and they have coronary calcium scores that they calculate, since coronary calcification, as we know, is a sign of atherosclerosis, and that even within the brain on a plain CT, if you see calcification, it's highly associated with stroke recurrence. Was there anything that you had found that was trying to find something similar?
Calcium scores for ICAD. I don't think there's like valid data in this regard. Yeah, no, I don't have the answer for this question, whether they were able to use the calcium score for the vulnerability of the plaque or not. But it's a nice thought, yeah.
One of the things you mentioned was that the lumen doesn't necessarily associate with, what type of risk they're, going to have for stroke and recurrence, and that also applies with calcification of plaque in the internal carotid artery.
Yeah, yeah. No, it's a nice thought, actually. Maybe we can do it here if, know like good data about it.
There was like a score where it was kind of like you had like calcification in the internal carotid artery on a plain head CT plus, like as we have with some of our other scores for stratification. patient, like something else you could help sort of find those patients when it comes to, like, for example, like PFO selection. You know, sometimes you have to kind of, in order to find the patients, find the risk factors.
Yeah. Yeah. Okay. And anybody from Zoom? I'm not sure. Yeah, I'm losing track of Zoom. All right.
I know for myself, I just look on their CTA and I look in their aorta and I look to see what other diagnoses they have from